Okay, welcome everybody. It's Valerie Bogart with the Evelyn Frank Legal Resources Program, and we're here today talking about getting ready for the new annual enrollment period, which begins in just about 2 weeks, October 15th. So every year since 2006, there's always changes. And so we have some new people who are new advocates this year. And why isn't this letting me advance my screen? That's not good. And so we're going to go over basics. And while we go over basics, we're also going to be talking about what's current this year. So even if you feel you know a lot about Part D, you might want to stay tuned in the whole time and not just think that I'm getting to the news later, because I'll be sprinkling in some changes all throughout. So we're going to start with some basics about how Part D works, coverage and costs. We'll first cover it for people without any subsidy. Then we'll talk about the key subsidies for people on Medicaid, Medicare Savings Program, and EPIC. Then we'll get into the nitty-gritty of what are the plan choices, this year, and what's the landscape this year. Then we'll go more into the enrollment procedures and things like that. So it's a lot to cover. We're going to hold questions. And Sarah Rakin, who is a paralegal with the Evelyn Frank program, will be reviewing the chat. And at strategic times, we might take some questions or we will get to them at the end. So just to lay out the full landscape for everybody so we're on the same level playing field, we just want to go through the Medicare parts, the A, B, C's, and D's of Medicare. So Part A is the hospital insurance. And inpatient, it also covers skilled nursing facility, which people mostly use for rehab. And nothing is simple. It also covers some home health care, which doesn't sound like hospital. But Medicare is confusing. There are lots of costs with Part A. There are deductibles if you go to the hospital. There are co-payments. There's no premium for most people if they're insured. And if you're uninsured, the premium is as much as $448 a month. They haven't announced the 2021 premiums yet, but it will no doubt go up. If you're low income, Medicaid will cover the cost of that premium if you're not otherwise insured. And HRA has just expanded its tools to make sure to identify people who are on Medicaid who may not be on Part A, but should be. And they've enrolled, I think, hundreds and hundreds of people, even 1,000 people in the last few months, and will be enrolling more. There's a new Medicare card for the last year or two, and they need this new number now. Gee, this is not the new Medicare card, is it? We got to get the new Medicare card up there. Then there's Part B, supplemental medical insurance, which we usually consider for outpatient coverage. And we think the premium, I've heard through sources that the premium will be going up to $153.50 this year. This does not cover prescription drugs, but it does cover most other outpatient care. Again, for low-income people, they can get help covering that premium through the Medicare Savings Program, and that is a key benefit to know about because, as you'll hear later, that's how many of our clients qualify for extra help with Part D. People who have more income or assets might prefer to purchase a Medigap policy and to help with their out-of-pocket costs for Part A and Part B. And there's a link there. You can get updated information on that. Then we have Part C, and this is sort of a very confusing part of Medicare because there is no Part C benefit package. It's just a name for receiving Parts A and B coverage through a different insurance model. It's the managed care model called Medicare Advantage. So anytime you hear that word advantage in insurance, it's a key to knowing that this is a managed care model. And we'll talk more about what that means. So this plans must offer Parts A and B services, and they may offer some supplemental benefits beyond what Medicare covers as an enticement for people to join these plans. And there are different types of Part C plans. They're really not called Part C. We really call them Medicare Advantage or MA plans. You don't see in the marketing information the words Part C, but that's where it lives in the Medicare statute. So most of our clients would join one of these 4 types of plans. There are a few others, an HMO, which I think people are familiar with that concept, where they're required to go in network, a PPO, which means preferred provider organizations, where they may go out of network, but usually at a higher cost premium and maybe higher cost deductible or coinsurance. And we'll talk about special needs plans, which are targeted for people, many of our clients. A dual SNP is a special needs plan specially designed for our clients who have both Medicaid and Medicare. So we will talk a little bit about those and ones for people in nursing homes. Now, the federal government is really pushing Medicare Advantage, especially during this Trump administration. I've learned that, look at these statistics, the number of Medicare Advantage plans has gone up over 75% nationally in just the last 3 years. And when you think about it, just in New York State alone this year, 276 Medicare Advantage plans are offered. Now, each of them is not in every county. Any one county might offer 40 or 50 or so plans, but that's a lot of plans. So you know that there's a reason why so many plans are offered, and we'll talk about that and help with helping counseling our clients on their options. So more on that later. So now we're to Medicare Part D, and it is only for people who have Medicare, either Parts A or B. They don't need both. And they have 2 choices of models to enroll in, either a standalone prescription drug plan, and we'll be abbreviating that PDP, or a Medicare Advantage plan with prescription drug coverage, and we abbreviate that MAPD. So this is all outpatient prescription drugs and drugs for nursing home residents. So it's not only outpatient, but it does not cover drugs while you're an inpatient hospital patient. All plans have utilization management rules, which we'll discuss, and they limit what drugs are covered by a drug formulary. We'll be talking about that. And all plans have different structures for how consumers or members are billed. So let's do some more building blocks. What drugs are covered by Part D? So the formulary is the name of the list of drugs that any particular plan covers. So when Part D started, the federal government was aware that some plans may try to get away without covering many drugs. So they identified 6 classes of drugs where it's so crucial that the consumer have access to at least 2 minimum drugs. So in these 6 classes, well, in all classes, the consumer must have at least a choice of 2 drugs. And those are different classes like cardiovascular drugs, or, you know, there's so many different types. But out of all those categories and classes, there are many. They identified 6 classes where it's so critical that the plan has to cover not only 2 drugs, but they have to cover all or substantially all generic and brand name drugs. And I'm not going to read this list, but you can see that this is reasons why these are critical categories. Anticonvulsants for people with seizures, people who had organ transplants, so immunosuppressants, people who have HIV/AIDS, antiretrovirals, and cancer drugs, antipsychotics, antidepressants. Now within those, they do have to cover a lot of the drugs in those classes, but they're still allowed to impose utilization management in those 6 classes, but they're discouraged from doing so for this one, the HIV/AIDS. And if a member is already taking a drug in one of these 6 classes, a plan may not add new utilization review requirements for those. Now, I'm not sure if that's still true year to year, or if that's only in the benefit year. I don't know that offhand. Now, plans are allowed to change their formularies at any time, but only if enrollees are currently taking the affected drug. But if enrollees are, taking an affected drug, they are exempt for a formulary change for the remainder of the plan year. So typically, we see most plans changing their formularies from year to year instead of mid-year. But it does happen that they might change at mid-year. And if they do change at mid-year, they have to cover, they can't change it for a particular member, only for someone who's new to the plan. So different ways they can change their formularies is to take a drug entirely off their formulary, or they can move the drug to a different tier, a tier where the copayment is more. Or they can add extra utilization requirements that we'll talk about soon. They have to provide 60 days notice of these changes. And if they don't, there's a penalty. They have to cover that drug for the next 60 days for an existing member. Let's see, why is my, okay. So more protections for consumers. If within 90 days of enrollment, and let's say usually that's on January 1st, but it could be mid-year if someone is allowed to change plans mid-year through something we'll learn about later called SEPs, special enrollment periods. So if they have been taking a drug that is not on the plan formulary, then the plan must give a 30-day supply of that drug to allow the member to either switch drugs or request an exception to approve a drug. So this is called transition rights. It's an important right to know about, because a lot of people will not have looked at those formularies, and they'll be caught without warning and realize that their plan does not cover the drug that they had been taking. So during this 90 days, they have this protection. They can either get their doctor to change their prescription or request that their plan make an exception and authorize the drug. The National Council on Aging has an excellent fact sheet on this, and there's a link on your slide. If you didn't receive the slides by email, they are posted as a handout on your GoToWebinar, whatever that is called, that little pygmy-doo up in the corner. Now, some drugs are excluded from Part D altogether. They're just not covered by this benefit. So sometimes that's confusing. You have your client's list of drugs, you go on Plan Finder, you put in all the drugs, and you find that it's not covered, and you think it's that they're not in the right plan, but it's not covered by Part D. What's even more confusing is that you might see that some plans do cover even an excluded drug, and that even misleads you further to think that you haven't found the right plan. But the plans that may cover excluded drugs are called enhanced plans. So if a drug is technically excluded because it's in this list of drugs on your slide, then if the client has Medicaid, Medicaid will cover it, or also EPIC will cover it for people 65 and over. So instead of tearing your hair out trying to find a plan that covers it, you're going to instead think of alternate ways of getting these excluded drugs. Because if you do find a plan that covers it as an enhanced plan, chances are that's an expensive plan that will not be fully subsidized for people on Medicaid or with extra help or EPIC. So it's probably not a good enough reason to enroll in an enhanced plan in and of itself. But that's true for everything. For everything, you're going to want to really look at which plan most covers the covered drugs. If you've done this for a long time, you might not realize there were drugs that were excluded years ago when Part D started. They have benzodiazepines. We used to always joke that you needed Ativan and Valium to get through the Part D counseling, and now you can get those through Part D. They're no longer excluded, but all these other drugs are excluded. So as I said, Medicaid will pay for excluded drugs. If someone's on Medicaid, you still do need a prescription, but you can get them at the pharmacy counter. And EPIC will also pay for excluded drugs. I believe you also need a prescription for that. That's again only for people age 65 and over. Another reason you may not find a drug when you're doing Plan Finder is that it's not covered by Part D, but it is covered by Medicare Part B. And these tend to be drugs that are injected or administered through an IV in a doctor's office or in a dialysis facility, or administered with a nebulizer or an infusion pump. But there are some odd exceptions to this. The Medicare Rights Center has an excellent chart of comparing B versus D drugs. There's a link on your PowerPoint. That's a good reference because it does get complicated. But these are things that you want to think about when you're doing your plan search and think, okay, I'm not finding this expensive drug because it's a Part B drug. Now, I'll say that Medicare Advantage plans do have to cover everything under Part B, right? But remember that Medicare Advantage plans, well, we'll get to costs later, but I've had personal and professional experience with this. These Part B drugs, like certain chemotherapy, can be really expensive in a Medicare Advantage plan. And since Part D doesn't cover it, you can't use extra help for these. So even if you're on Medicaid, if you joined a Medicare Advantage plan, that plan might be cheap in many ways, maybe no premium, maybe no deductible, but it can charge a 20% coinsurance for these expensive Part B drugs. So these are important factors when you're helping someone search and select a plan, it's important to find out, are they taking any Part B drugs? Because if they are, even though you're not going to find them on Plan Finder, that's going to be a factor in helping them select a plan. Certain vaccines are, how confusing is this? Some vaccines are covered by Part D and some are covered by Part B. We'll have to consult these charts or this slide as reminders, because I know I could never remember them. And the other issue that when you're picking a plan is to think about what utilization management limits are there for the client's drugs. Because the plan might have a prior authorization requirement, requiring that the physician show the patient has a certain diagnosis or certain test results in order to cover the drug. There might be step therapy, where the member has to first try some alternate drugs, perhaps a generic drug, and the doctor has to show that it was ineffective or it had adverse side effects. Then there can be quantity limits that if the person takes 2 a day, in the Plan Finder, you'll want to enter that they need 60 a month, because then it will show, I believe this year they've improved it, so it will show the quantity limits. Because if the quantity limit is 30 a month and the client takes 60 a month, that means they will need an exception to be approved for them to get the quantity that they need, and you'd rather find a plan where 60 is within the quantity limit. If there's no plan that has 60, that within its quantity limit, then you'll have to deal with the exception. But this is the kind of thing that you'll be looking for. So when you do the Plan Finder, you definitely need always to know the strength of the medication, because it might cover 6 milligrams of a medication, but not 12 milligrams. And you want to know the quantity limit. So as we said before, in those 6 protected classes, they are allowed to impose these utilization management, but they can't put new limitations on for existing members who are taking drugs in these 6 classes. All right. All right, let's just see, are there any questions just up till now, just along this
I think we just got one. Sorry, this is Sarah from Anne. It says, I always thought a dual eligible client can get Medicaid to cover the 20% not covered for a Part B drug. Is this not the case?
That's a good question. If they have full Medicaid or Quimby with no spend down, then I think that answer should be correct. But there's a lot of Medicaid recipients who have a spend down, and let's see, let's just think about that. I think that was the case for one of my clients, that they didn't have full Medicaid. They had a spend down. Or you might have somebody who's has only, they're in SlimB or Quimby or QI1, so they don't have Medicaid coverage. They have extra help. They're still low income, but they don't have that wraparound for Part B. So yeah, but that's a really good question, and we'll make a note just to check that. So now we're going to go through the different phases of Part D. I do not know why. Okay. The different phases of the cost. There's a premium, there's a deductible, there are co-payments. There is no longer a coverage gap, but there's still a period of time that we sort of think of as the coverage gap, and then there's catastrophic coverage. So you're going to learn what this looks like for 2021. So in New York State, well, first we're going to talk about the standalone prescription drug plans. So I haven't mentioned this yet, but there are 28 plans in New York State this year. And the average premium is $45.03. The highest premium is $94.80. The lowest is only $7.30. Now, when you see plan descriptions, you're going to see some terminology, and these are important things to know, that there are basic plans and there are enhanced plans. So for the basic plans, if their premium is under $42.27, these are called benchmark plans, and they are free. They have no premium for people with extra help. That's the full extra help subsidy for people on Medicaid, Medicare Savings Program, or if they applied for extra help through Social Security. There are only 7 plans out of the 28 in New York State this year that are in our benchmark plans, and we'll look at a list in just a few minutes. The basic deductible is now $445. That's gone up. Now, a number of plans have a 0 deductible, 4 plans. Other ones range, all the way up to the maximum. And you like everything, you're always going to have to weigh all the factors. Like, people think, oh, I want a plan with no deductible. Well, you don't want a plan with no deductible if that plan doesn't cover your drugs at a low copayment and without the authorization requirements. And you don't want a low premium plan if that plan also doesn't cover your drugs. And for people with extra help, we're not going to worry so much about the deductible because their deductible is going to be covered. So those clients might get lured through marketing saying, our plan has no deductible. And you say, well, you don't have a deductible anyway because you have extra help. So all of that is possible, important for counseling, because our clients hear messages that, it's just true anyway. Even if they weren't in this plan, they have no deductible. So the co-insurance and co-payments, most plans, the prescription drug plans, standalone plans, they have tiers, and I looked at an actual plan from 2020, and this is what their tiers look like. So you can see it's very cheap at the first 2 tiers, or generics. Then it starts getting more expensive. 38% of the cost of the drug, 27% of the cost of the drug. Now, don't forget, these specialty tiers, this might be a drug that's $1,000. So 27% of that could be, $270. I mean, these are very expensive drugs at the top, or more. They also could just charge across the board 25% co-insurance, but not many plans do that. So when you do Plan Finder, it will tell you which tier a drug is at and what the plan's costs are. So that's really key. Other things that affect costs are what pharmacy the client goes to. It's very important because the plans contract with certain preferred pharmacies, and those costs will be lower. And of course, extra help will reduce these costs, although they won't reduce these costs at $0 and $1. Those are already very low. So here's the standard structure for Part D in 2021. And I know this looks sort of overwhelming, but we'll just talk through it and you'll get a sense of how it works. So first there's a deductible where the client has to pay the full $445 of drug costs before the plan starts to cover. But she's already, even though she's in the deductible period, she's paying a premium and she's still giving her membership card to the pharmacy to swipe. And even though the plan won't pay anything in the deductible period, the charge that she's paying, like the plan's rate, will count towards her deductible. So that's why it's very important that she gives her plan card. So once she meets her deductible, she's in something called the initial coverage period. And this is where there could be a 25% coinsurance, but as I said before, most plans instead have her pay costs on these different tiers, just like on the last slide, a percentage or a flat rate for different tiers. And this will go on until in this phase, she's paid $1,032.50. If her plan does charge 25% coinsurance and the plan's paying 75%. If she's paying tier prices and the plan's paying everything above the tier. So she paid $445, now she's paying $1,032. And at the end of this period, the total costs paid by her and the plan in this period are $4,130. So then she's in what used to be called the coverage gap, but there really isn't one anymore. In this period, the consumer will never pay more than 25% of the cost of drugs. And I guess plans might vary. Maybe in this period, they'll still have them continuing to pay their tiers, or they'll have them pay 25%. But once they've been in this period and their full costs reach $5,183.75, then she's in catastrophic coverage. And here, the cost will drop to either 5% of the cost of the drug, or these flat fees, $920 for a brand name, whichever is greater. So I just did the math here. Up to $184 for brand name drugs, she'll pay the $920, and then after that, she'll be paying the 5%. So what's good is that the coverage gap is closed. It used to be that the client was paying 100% in this part 3 of it. Now they're paying at most 25%. Now don't forget, this is for people without extra help. This is people with no subsidy and without Epic, because their costs will be also much lower if they have Epic. And I want to put in a plug. Last year when we did Part D counseling around the state, I found a lot of people over 65 did not know about Epic. I don't mean over 65, age 65 and over. And that has to become part of everyone's screening, because Epic will help at each and every one of these stages. It is on a sliding scale, so that costs go up with income, but it's much more, it will help really anyone at each of these stages.
Val, I think we have a quick question going back to 2 slides. There was a question about tier 4 said it was 38%, but the tier 5 percentage was 27%. So someone was, the slide before that. So someone was wondering if that is a misprint, and if not, could you just explain?
You know, that was, I actually went into Silver Script's plan. So I think what this is 4 is the reason it's different is that the tier 5 drugs are so much more expensive than the tier 4 drugs that even with a lower percentage, it's still a lot of money. Do you see what I mean? 27% of 1,000 is more than 38% of 250.
Oh, right.
Right? So I think that that's where it came from, but this is what it was. Now this year it might change. The 2021 structures weren't available, but this is what SilverScript was, which was a very popular plan last year. Unless I copied it wrong, I may have, but I also thought that was odd, but that's what I think is the explanation. Okay, so a chart, a different version of a chart of this is posted in the handout section from National Council on the Aging. There's so many different ways of showing this, so feel free to download that. I'm sure Medicare Rights Center will have a chart soon, or if they don't already, for 2021. But I don't think people really need to know these figures. It's just a sense of how long it will take to move through these different phases. All right, it seems that doesn't, I do not understand why okay. So just to show that in the last few years, these costs have gone up a lot. Like, just look at the figures in red here. In 1 year, from 2019 to 2020, the out-of-pocket threshold went up $1,250 in 1 year. And that's means the person had to spend that much more until they got into catastrophic coverage. So, you know, costs have, the amount that any individual has to spend until they get up to catastrophic coverage has definitely gone up over $1,500 just since 2018, making it even more important for anyone 65 or over to join EPIC, and anyone who can qualify for extra help to get extra help. Now, when you're moving through those different tiers, this is a concept. TROOP is the concept of which are your true out-of-pocket costs, which costs count for you to move through those tiers. So for one thing, only what you pay for formulary drugs count. So not drugs excluded from Part D, not drugs that are over the counter, not drugs that were denied by your plan and you thought, oh, I'm not going to bother with fighting the plan and appealing to get an exception, I'm just going to pay for it. Well, if you do that, the cost of that will not help you move through to this catastrophic coverage. So it's always better to appeal if the plan denies it, because you might win. If you buy drugs in Canada or Mexico, those don't count. The cost of those don't count. Also, I don't think I put it on here, but if you buy drugs at a pharmacy that does not, oh yeah, a non-network pharmacy, you have to go to a network pharmacy or the cost will not count. But here's a really nice thing. Even if EPIC pays for a drug, or ADAP, which is the drug subsidy program for people with HIV or AIDS, then those costs help move you through to catastrophic coverage. So it's not only what you pay, but sometimes what the subsidy pays that can help you through that. And that's even if you get a payment in cash from a pharmaceutical assistance program. They usually don't pay in cash, though. They usually just subsidize the drug, in which case that does not count. They just give you a discounted drug. So you have to be aware of what payments do not count toward TRUE, that do not help you move through the different stages up to catastrophic coverage. In that last stage, this is not catastrophic coverage, but in stage 3, what's a little confusing is that when you're paying 25% for brand name costs, the manufacturer is paying 70% and the plan is paying 5%. So the part paid for by the manufacturer also counts towards that limit that you have to reach to get to catastrophic coverage, which is a good thing. That can help you get there faster, but not the cost paid by the plan. I don't know how they made up these rules. They're so confusing. As I mentioned before, pharmacies, and it's not only a question whether it's in network or out of network. You want to look to see whether they're preferred in network or not preferred in network. And this will all show on the plan finder. We heard that the search mechanism for pharmacies is better this year. It was terrible last year. Supposedly you'll be able to just identify them and keep them as preferred when you do the client searches more easily. There are mail order pharmacies, but again, you've got to be sure to use everything preferred by the plan. And that's a factor. I mean, some people still go to a little mom and pop pharmacy that's not in the chain in their neighborhood. And you want to make sure that plan contracts with that pharmacy, or the client will really be bad off with Part D costs. Nursing homes contract with long-term care pharmacies, which are a different type of pharmacy. So that's sort of a different sort of search. All right. Sarah, any questions up till now?
No. Oh, sorry. Yes, we had one other question. Will the plan finder reflect that under COVID easements, you can request 90 days of a prescription when normally only 30 days at a time is covered?
Oh, I don't know, and I actually forgot about that, so I didn't cover that. So what's the easement? You can get 90 days. Can you just read that again so we all know?
Yeah. So it says, will the plan finder reflect that under COVID easements, you can request 90 days of a prescription when normally only 30 days at a time is covered?
That's a great question. We'll make a note of that and look that up.
Yeah.
But it's a good reminder that you can you can ask for 90 days coverage, because they were trying to, I remember that early on in COVID, they were trying to limit people from having to go to the pharmacy so frequently. So that's good. All right, we want to look at how extra help helps pay these costs. So extra help is a fantastic benefit. It's the subsidy itself is administered by CMS, the Medicare and Medicaid agency, but eligibility for extra help is administered by the Social Security Administration if you don't have Medicaid or the Medicare Savings Program. So that's also confusing. But in New York, most people, the vast majority, do not deal with the Social Security Administration because they get extra help automatically because they're deemed eligible by being on Medicaid, which includes everyone on SSI, and everyone in the Medicare Savings Program. Or you can apply to Social Security separately for either full extra help or partial extra help. So the full extra help income limit is 135% of the federal poverty line. So that is the same as our most generous Medicare Savings Program, QI1. So because that income limit is the same, that's why it's almost always better to apply for the Medicare Savings Program rather than applying to Social Security if you're eligible for full extra help, because if you apply for Social Security, there is a resource limit. And look at these resource limits. They're well below the Medicaid resource limits in New York State. So, and if you're eligible only for the Medicare Savings Program, you know, there's no asset limit for the Medicare Savings Program. So for all of those reasons, you're really always better off applying for an MSP and then automatically getting extra help that way. And then also you save the Part B premium, which is a lot of money, and it's going up more. Now, for those whose incomes are above full extra help, but they're under the partial extra help limit, so that's, you know, in this threshold up to $1,596 for a single, $2,155 for a couple, that's where it could be worth investigating. Are they eligible for partial extra help? But and then applying for Social Security. But they have these resource limits, and they do not have the same exclusions from resources that we have for Medicaid. They do exclude the cash value of life insurance, which is good. That counts normally for Medicaid, but they count the IRA principal, and there is no spousal refusal in extra help. You must count the spouse's resources. And just another strategy tip, another reason why someone might apply for Social Security extra help, even though they're also applying for MSP, it's just faster. It's almost instantaneous. You can apply online and get approved. I forget how long it takes, but like a few days or a week to get full extra help. Whereas an MSP application has to be filed through HRA or your local district. It can take time. And so if the client is eligible for full extra help because they're under the resource limit, we recommend doing both. Apply online, get the Social Security full extra help, and at the same time, put in an application for an MSP because they still want the full MSP benefit with the Part B subsidy. So that's a strategy tip. Now, we're not going into, we could spend an hour going into how Social Security counts income and assets and household size, so really recommend you look directly at the POMs because we're not covering all of that, just these few little tips here. So what does extra help pay? This year in 2021, here's the new amounts. So as we discussed, the benchmark premium, it'll pay your premium up to $42.27. New York has the highest benchmark premium in the whole country. So that's a really nice benefit. In partial, it pays a percentage of the premium. The client still has to pay a percentage. The deductible, you pay nothing. The entire $455 deductible is subsidized by extra help. In partial, it's partially subsidized. And here are the new co-payments. They went up slightly from last year, not a lot. And I was reminded by my coworker, Peter, thank you, that there is a zero co-payment for people in nursing homes, the managed long-term care program, and all of these waivers, the traumatic brain injury waiver, the nursing home transition and diversion waiver, and the OPWDD waiver. So everyone else on Medicaid or extra help has to pay these co-payments, maximum of $920. You can see there's 2 tiers of co-payments even within full extra help. That's based on income. Partial extra help, it's a 15% cost sharing, or the plan co-pays if they're less. I showed you that the tiered copays of only $1 for generics. So a person with partial extra help would pay $1 because that's less than the 15% cost sharing if that's the drug. Once they reach catastrophic coverage, the copays are eliminated. There's no cost for people in extra help. And for partial extra help, it goes down to the same copayments as what applies for full extra help earlier on. So you can see the subsidies are really important. But reminder, these great subsidies only apply for covered drugs by the plan. This does not help you if a drug is off formulary or if there's utilization controls that you have not been approved for. So this is not a get out of jail free card. It does not waive all of those requirements. You still have to find the plan that covers your drugs. But if you have full extra help, you can be less concerned about, does the plan have a premium? Does a plan have a deductible? And let's say the plan you find has a $60 premium. Well, you'll still get this benchmark premium subsidy of $42.27. It might be worth it to you to pay the difference in the premium if, say, you're taking some very expensive brand name drugs that are only covered by that plan at your dosage and at your strength without utilization controls. So all of those things need to be weighed. So just don't be a one factor searcher. Look at all of the different factors for each client, like whether all their drugs are covered, and then you're weighing the different costs. So again, a plug for the Medicare Savings Program. This is David Silva's old slide that it rocks. It's a great subsidy. It saves so much money for our clients. And just the extra help benefit is supposed to be worth about $4,000 a year. Another benefit that I haven't mentioned is that if your client enrolled late in Part B or Part D, being in the Medicare Savings Program gets rid of their late enrollment penalty. Now, I understand it's more restricted now, and I'm not sure about what that means. I left that in as a placeholder, but I didn't find that limitation. So if anyone is really concerned about that, put that in chat and we'll look that up, what the limitation is. Or if anyone knows what it is, put that in chat. Just by being in the Medicare Savings Program and having extra help, you get a special enrollment period for both Part B and Part D. And there's no resource test. So in that way, it's so much better than applying for extra help. It's a one-page application. And with Quimby, one of the 3 Medicare Savings Programs, you also get the cost sharing for Part B and for Part A. So every case, we have to screen for potential eligibility for MSP. And it has cute acronyms: MSP, QI1, SLIMB, Quimby. So as we said before, because there's no asset test, it's better than applying for standalone extra help. A pooled trust could be used to qualify someone for MSP. So even if they're over income, it may be worth it for them to enroll in a pooled trust just for MSP, even if they don't need Medicaid. And as we've covered this before. Now, let's say you were in extra help last year. Do you have to reapply this year? Maybe. Okay, so these are these rules called redemption, which sounds like a violation of church and state, but it's not. It's a Part D term. So if you have Medicaid for just 1 month in the current year, in 2020, you get extra help for the entire year. If that 1 month that you have Medicaid is in the last half of the year, then you are redeemed. You get extra help for the rest of this year and for all of the next year. That's called redemption. You are redeemed into extra help for the following year. So we always really want to try to get clients Medicaid in the last half of the year, even by meeting Medicaid spend down for just 1 month. So this is a tip that we use if the client's income is over either MSP or the Medicaid limit, but they're eligible for Medicaid with regard to their resources. They can use past bills to meet their spend down just for 1 month, and then they can use this trick. And I think there's an example. Yeah, so here's an example. We have Tina who gets Social Security disability of $1,500 a month. So her spend down is about $600. She's under 65, so she doesn't qualify for EPIC. Her resources are under the Medicaid limits. She comes to you in July 2020. So you ask her, you add this to your intake. Do you have any past unpaid medical bills from the last 6 years that are still viable, meaning they are still subject to collection? If she's actually still receiving collection bills, that's the best. But even if she's not, if they're less than 6 years old, the creditor, the provider could still sue on them under the 6-year statute of limitations. So they should be considered viable. If she paid medical bills that were incurred in the last 3 months, these can also offset the spend down in the month of application. So she tells you, she has an unpaid medical bill from 3 years ago of $500, and it is in collection. And she also paid $100 in co-payments in the last 3 months. So you add up both 500 and 100. Those meet her $600 spend down in the month of application. So she's applying in July. She'll get extra help for the rest of 2020 and all of 2021 because her Medicaid was active for at least 1 month at the end of 2020. Now for COVID, thanks for the reminder about COVID, our clients have some advantage also because Medicaid rules have been eased so that anyone who had Medicaid since March, even in 1 month, beginning in March 2020, when their Medicaid was up for renewal, it got renewed for 12 months. So even if normally they wouldn't have had continued having Medicaid till the end of the year, they all should have Medicaid till the end of the year, which gives them all extra help for all of 2021. So that's a small silver lining of COVID. Now, just again, to remind you about EPIC, there's no asset test. It's for anyone over 65. The income limits are much, much higher than any other income-based program. There's the fee plan has these $20,000 a year for singles, $26,000 for couples. They do have a fee they have to pay, but it's waived for people with full extra help. If they have full Medicaid, they're not eligible for EPIC, but if they have a spend down, they are. So it's still worth applying, even if they have a spend down. And these fees are low, relatively speaking, for the benefit that they'll get by being on EPIC. the deductible claim goes all the way up to $100,000 a year for couples and $75,000 a year for singles. Now, they do have a deductible. It can be substantial at the higher income limits, but it's still worth it. And in the later slides, I'll just show you some examples of how EPIC wraps around Part D and really reduces costs. But we wanted to get into the nitty-gritty of choosing a plan and what are the differences in the plans, and we're going to look at the New York plans. So option one is to have original Medicare, having your Part A and B, so that you, using your Medicare card to see any Medicare provider of your choosing, without needing permission of a managed care plan, and then enrolling in a standalone Medicare Part D plan. This year, there are 28 plans and sponsored by 9 companies. So this gives you an idea of how hard it is to pick plans. People say they want AARP. Well, AARP might have 4 plans this year. So we're going to look at the list and just highlight some changes about it this year. At their option, they can join a Medigap plan also, because that helps with A and B costs, but it has nothing to do with Part D. The option 2 is we called it by its formal name before, Part C, but we know it as Medicare Advantage with prescription drug coverage, or MAPD. You must have A and B to be eligible, and we looked at some of the main plans before, and these are some of the plans for higher income people, high deductible plan, not very common for our clients. So the costs in the Medicare Advantage plans really vary. Some have no premiums, some have no deductibles, but some do. They don't have to be exactly the same as original Medicare. They can just be actuarially equivalent. So that makes it very hard to compare. There's one benefit in Medicare Advantage that is not in original Medicare, and that is something called MOOP. That stands for Maximum Out-of-Pocket Costs. So when someone, all their deductibles and all their copays for the services provided by the plan under Part A and Part B meet this maximum cost, which in this year is $7,550, they will have no more out-of-pocket costs for the year. Now this has gone up quite a bit because the ACA had capped MOOP increases, but it only capped it for 5 years. So that cap expired in 2019. In that 1 year, MOOP increased $1,250, just like the other figure we looked at increased, but in 1 year. So you have to be careful because some plans have a different MOOP out-of-pocket cap for in-network costs versus out-of-network costs. So the MOOP applies to their in-network costs. So you have to wonder, in-network, if someone reaches that limit, then they had just bad luck, because at $75.50, what is that? That's about $600 a month. So they could have easily enrolled in even a fancy Medigap plan for $600 a month. So like, if someone is really likely to meet their maximum out-of-pocket charges, I don't really see why they would do Medicare Advantage instead of just picking a good Medigap policy. But of course, many people don't plan on getting cancer or having a stroke. So these things just happen. So even healthy people, of course, can have unexpected huge medical costs, and then that MOOP would be beneficial. So some pros and cons for Medicare Advantage. Why do many of our clients want to join these plans? In original Medicare, your Part B coinsurance is 20%. So many of these plans, instead of charging 20%, have a fixed copayment. So for a primary care doctor, it might be $30. For a specialist, it might be $40. And that's a fixed charge instead of 20% of an unknown. So in that way, it can be more predictable. And it may be cheaper because many of these plans have no premiums and Medigap is expensive. And they have additional benefits. Many of them for a long time have offered some dental or gym coverage or cash cards for over-the-counter. But what's really increasing this year and just started last year are these supplemental benefits that we'll talk about a little bit, which are really ramping up. Disadvantages, people are locked in unless a SEP applies, and one SEP applies January through March of every year. So if in January through March, if someone in a Medicare Advantage plan says, whoops, I should not have joined this plan, they can get out of it from January through March. And there are other SEPs. The provider networks are probably the biggest disadvantage of a Medicare Advantage plan. And for the lower cost ones, they're going to have a more strict provider network. They're going to be HMOs with no out-of-network coverage instead of PPOs. Their drug formulary also now is a downside. Now you might say, well, that's a downside for all prescription drug plans. True, but here you have to have one plan cover all of your preferred providers and all your drugs. So you have less chance of finding one plan that covers everything than finding it sort of a la carte among plans. And there are some new services we'll talk about covered by Medicare Advantage, like dialysis and acupuncture. And all of those will have to be in network. They're going to be advertising them this year because they're sexy new services covered by Medicare Advantage. But that asterisk is going to be, is your provider in network? They also do more utilization management than is true in original Medicare. Now, until now in original Medicare, there was really no utilization management for Part A and B. I understand some new prior authorization rules for outpatient procedures are starting in original Medicare. There's a PDF here from CMS. I haven't really learned those rules, but they're for like things that could potentially be cosmetic. Things like rhinoplasty, which I think is a nose job. So they're going to be doing some prior approval procedures to make sure it's not a cosmetic procedure and make sure it's medically necessary. There's not for, major surgery that would have no possible cosmetic side. So you can see a list of those outpatient procedures in this PDF at the bottom. Disadvantages is a flip side of what the advantages are. And this is what I cautioned about earlier, that when you look at the plan's table of charges, they might have a $20 copay for this, a $30 copay for this, but then for certain charges, it will say 20% coinsurance, or it will say the full copayment that applies for skilled nursing facilities. And so if someone needs those services, and typically those Part B injections are 20% coinsurance, even in a Medicare Advantage plan. So those can be thousands and thousands of dollars unless the person has a subsidy, as someone pointed out before. If they have full Medicaid, that should cover it, but it won't cover it if they have QI1 or Slim B, or they have no extra coverage. So here again, at that you have the maximum out-of-pocket protection, the MOOP, but that averages out to $629 a month. That's a lot of money. Think about whether it could be more affordable and less anxiety provoking just to join a Medigap plan. So now we'll look at enrollment, but let's take a few minutes to just look at the plans in New York. And I hope all of you are familiar with the New York Health Access website, and we have an article posted with all the Part D plans on it. So I've already downloaded this chart, which is on there. So here are the 7 plans that are free for people with extra help, and their premiums if you're not in extra help. So these plans were also free last year, so people who were in them last year can be confident that they're still free this year. But are they still good for your client? They still need to check to make sure the formulary hasn't changed, to see if they still cover the client's preferred pharmacy, to still see if the client's drugs have changed. So you still need to review that, but at least they can stay in those plans without change. But here are 2 plans that were benchmark plans last year that are no longer offered this year. And between them, they had almost 40,000 members in New York State. So that affects a lot of people. If they had extra help last year, they will be reassigned to a new plan for 2021. However, warning, that reassignment is random. So they'll be reassigned to one of these 7 other benchmark plans. You have to check. They have to check to see, does that plan cover their drugs? And in December, they'll get a notice from Medicare that actually tells them, okay, last year you took these drugs. The plan we're assigning you to does not cover these 3 drugs. So that's a really nice service that is being provided. I wish they did better, and they only assigned you to a plan that covered your drugs, but it's a warning sign that says you better pick a different plan. Now, you might say December, that's sort of late because the open enrollment period ends December 7th. Well, people who are in a plan that's closing have a SEP, or special enrollment period, to change plans all the way through the end of the year. So that notice really is in time for them to pick a different plan and change by the end of the year. And even all the way through February 2021, they can change. But that won't help them for January to be in the right plan. Even people who don't have extra help will receive notice warning them that their plan is closing, but they are not reassigned to a plan if they don't pick one. So they really need to be, these 40,000 people or so, if they don't have extra help, they really need to be doing a plan finder and picking a different plan. So also in this article is this list of standalone PDPs. So I'm just going to show you this list that you're free to download. And what we've added to this list are some extra things that CMS doesn't put on it. You can sort it all sorts of ways from the highest premium. This one shows you which plans closed It also shows you what was their star rating last year, which could be helpful. And it also shows you for people not in extra help, how much has their premium changed from last year to this year. So while you're doing your plan finders, this could be a helpful thing, especially for people who are not in extra help, to see. It also tells you if it's a basic plan or enhanced plan. And it tells you the number of people who were enrolled in it last year. So you can see the big, very popular plans. But we might come back to that as we continue. Okay, enrollment. So we're now in the open enrollment period. It's also sometimes called the annual enrollment period. Starts October 15th, it ends December 7th. Now, this is for everybody every Medicare beneficiary can use this period. And no matter when they join during this period, the change is effective January 1st of next year. There's also the initial enrollment period for people who were newly entitled to Medicare. And that's a 7-month period around the month that they become entitled to Medicare. Sometimes they overlap. That has special rules, which we're not going to go into. Now, this is for everybody. You can enroll in either a Part D plan or Medicare Advantage plan from October 15th to December 7th. This other enrollment period in the first quarter of 2021 is different. This is a Medicare Advantage open enrollment period, and it's restricted to certain changes. You can change between Medicare Advantage plans. You can change out of a Medicare Advantage plan back to original Medicare with Part D or without Part D. That's an example I gave before. The person who realized, whoops, I should not be in this plan. I prefer to join a Part D plan. But you can't initially enroll in a Medicare Advantage plan in this period if you were not in one. And you can't change your standalone plan in this period. And it's one change only. Now, there are other steps that might allow you to make these other changes, special enrollment periods, which we'll talk about in a minute. But using this open enrollment period, you can't make these other changes. Let's see. So there are lots of steps, and Medicare Rights Center has a terrific chart that's I think the link is on our NILAG New York Health Access webpage. There is a new COVID SEP that I'll mention briefly. And what they did was they extended the disaster SEP to include COVID. So the disaster SEP that normally applies to earthquake areas or the fire areas has been extended to include nationally anyone affected by the pandemic. And they've also expanded this to not only federally declared emergencies, but state and local emergencies. So this is a SEP that you can make any changes with prescription drug or Medicare Advantage since COVID was declared a national disaster March 13th. Now, but you must have had another valid election period at the time of the incident period, which you did not exercise. So like in May, people were not normally allowed to switch plans, right? So in May, they couldn't have used this SEP to switch plans unless they had another SEP, another valid election period at the time. Like, let's say they were at the end of their 7-month initial SEP, but now they couldn't enroll because, and I didn't put it here, but because they're in an emergency, or a person that they rely on, their daughter or their sister, who usually helps them, is affected by the emergency. So they couldn't exercise an election because they or the person they depend on was affected by the emergency. So we've identified 2 prescription drug plans that are closing in 2021, and there's a third one that's closing, an enhanced plan called Journey RX Value. So there's a SEP for any members of these plans, and we just gave you examples of that on that Part D benchmark chart. But anyone who is in these plans in 2020 has to pick a new one for 2021. Those with extra help are being randomly reassigned if they don't pick one. And as I said, better to pick your own based on your own needs than be randomly reassigned. And they all have a SEP that goes from just when the regular enrollment period ends December 7th, all the way through February 28th of next year. So they'll have this extra time to switch plans. Or those who didn't have extra help might find themselves with no Part D plan at all in January if they don't pick one. So they will have the SEP to enroll in one for February. If they enroll in January, it's effective in February. If they enroll in February, it's effective in March. So additionally, if you're in those plans and you have extra help, you have these additional SEPs so that in the first quarter of 2021, they can make a change effective the next month based on having extra help. Also, those who are reassigned by CMS to a plan they don't like, actually, for 2021, this should read, can change plans in the first quarter. So they might have a few bites at the apple, a few chances to change plans. So this is the same idea. Anyone who is auto-enrolled by CMS or New York State has a one-time SEP. May make a one-time election before the enrollment is effective or within 3 months after the enrollment to change plans. So who does this apply to? Well, everyone on Medicaid. If you apply for Medicaid and you were not in a Part D plan before, then you automatically get extra help and you're automatically randomly assigned to a benchmark plan. So that's one group who's auto-enrolled by CMS. Another group are people who have EPIC. If you enroll in EPIC and you weren't yet in a Part D plan, you will be assigned to a plan intelligently, not randomly. And that means that if EPIC has a record of what prescriptions you've taken, they will try to assign you to a plan that has those drugs in its formulary. Or people who are reassigned, like people who were in those plans that were closing if they were reassigned. So it's these people who, once they were assigned, say, wait a minute, I don't want this plan. I didn't pick this plan. I want to change. They have this SEP to change. People with extra help have some rights to change throughout the year, but these change in the last few years. They can make a change once per calendar quarter in the first 3 quarters of the year, but not in the last quarter, and not if they have misused opioids. These are some new restrictions. If they are on record as misusing opioid drugs, they do not have this SEP. If they were just approved for extra help or changed the type of extra help, they also get a SEP to change plans, or if they lose extra help. But there are many, many more SEPs, which we're not going to go over. Some of them are summarized at the end of the PowerPoint. I knew I wouldn't get to that, so I just put them at the end. So feel free to read through those. It's always good. You don't need the SEPs right now because we're just at the enrollment period, but you could need it. Let's say you have someone who comes to you now and they need to change plans for November because they're in a terrible plan. They just got a new prescription and it's not covered by their plan. So you might need to make 2 plan changes for them, one for November and then one for the annual enrollment in January. Then if that's the case and you are switching plans, let's say you want to switch someone just for November and they have a SEP. Let's say they have extra help. Oh no, extra help you can't change in the last quarter. Let's say they have EPIC. The way they would change is simply to enroll in a new plan, and that switches them out of the other plan. Now, if they were in a prescription drug plan, I mean a Medicare Advantage plan, they have to be aware that now they'll be in original Medicare. So if they don't have Quimby or Medicaid, then they might need to be joining a Medigap. And these changes are effective the first of the next month. So you don't have to disenroll and enroll. It's just one step. Just by enrolling in a new plan, that will automatically disenroll you from the other plan. The late enrollment penalty. So this is can be very bad for people who missed didn't get the memo. They didn't know they had to enroll in Part D. And now they're enrolling. And they have a late enrollment penalty that goes for the rest of their life if they didn't enroll within 63 days of when they lost creditable coverage or when they first were eligible for Part D. And here's how the penalty works, and I got the 2021 figure. So if someone, it's 1% per full month without Part D starting in June 2006, or when they were first eligible, whichever is later. So it's based on this base beneficiary premium that CMS announces every year. The link is on the bottom of the slide. This year, it's just 3306. So a person who was delayed 10 years, I think I did the math right, although that doesn't look right, does it? 1% is 33 cents. Well, it's 33 cents a month. I hope I don't know if I did the math right. Sorry. Now that I'm looking at it, it doesn't look right. But it's 33 cents a month. So, but that can be a lot because these are premiums that are only like $20, $30. We've seen people with double their premium or more. So an extra help exception, if they get extra help, that whole late enrollment penalty will go away. So that's an extra reason why, even if they're not going to always be eligible for extra help, they want to join it by one of the strategies we talked about later to get rid of the late enrollment penalty. The same thing if a person on Social Security disability has a late enrollment penalty, when they become 65, they now have a new initial enrollment period, it being 65. So their late enrollment penalty will go away. And it's the plan that determines the low income penalty, and that's appealable. Let's see, Sarah, should I just take a second for any questions that have come up?
Sure. Okay, Kelly had a comment on the math.
On the
She
what?
said on the calculations you did,
Okay.
on the late enrollment penalty, she said she didn't times the amount by month, she just did it by 10 years. So it is really multiple by 120, not 10.
Right, I know, I did, that's what I realized. I did, oh, whoops, so did she do it?
I don't know. Kelly, did you do it? She didn't put it in here.
Yeah, so this is wrong. I'll send out corrected slides. Yeah, that's 10 years, right. It's gonna be much more 10-year delay. It'll be, we'll send out corrected slides. Much
Okay.
more. Okay, thank you, Kelly.
And then there was one other comment from a little while back. Anne said, there are supposed to be new efforts targeted at cooperation between the state and the counties to screen for MSP. I believe MRC is involved in implementing this. Hopefully in the not too far future, there will be more automatic enrollment in Quimby and Slimby, which I think you mentioned also.
Right, well, there's a couple initiatives. HRA has an initiative to identify people on Medicaid for MSP and buy-in, people who aren't even eligible for free Medicare. And there are efforts with, like, if someone applies for extra help at Social Security makes a referral of the case to, I believe, the local district, and tells the person that they might be eligible for MSP. So they're trying to coordinate more to identify people at these different entry points. So that's true. Yeah.
Okay, and then we heard back from Kelly. She said the penalty would be $39.67. So we can correct that.
Oh, okay. All right. That's, yeah. Thank you, Kelly. We will change this in the PowerPoint. So you could see that basically doubles, would at least, that's a lot more, $39.67. Thank you for catching that. Okay, so when is that penalty charged for enrolling late? So it's for people who, for those months where you did not have what they call creditable coverage, which is coverage that is as good as Part D coverage. So just because you have employer coverage or union coverage does not mean that it's considered creditable. Each employer, each provider of healthcare coverage has to give an annual notice of whether their coverage is creditable. And so that you are on notice that you need to join a Part D plan if it's not. Epic is not creditable coverage. It used to be initially in the early years of Part D, but it's no longer because it really only wraps around Part D. So Epic requires you, in fact, to enroll in Part D. And if you're not enrolled, it will enroll you. VA and TRICARE are both creditable, so that's good. So now we're getting into some tips on choosing a plan. Everyone has to learn Plan Finder. There's just no substitute for helping someone with selecting a plan other than entering their actual drugs and preferred pharmacies in, and seeing which plans cover the best. Now, as many of you know who have done this, some terrible changes were made in Plan Finder last year. This year, they got a lot of feedback from everybody, and they've improved some of these, but there are still these basic drawbacks in Plan Finder. So you can only do general searches still without entering a identifier for your client, which means that even though you take an hour to enter their 30 drugs in, that will not be saved. So you have to, every time, if they call you back a month later saying, okay, I've narrowed it down to these 3 plans, can you help me with these 3 plans? You have to still enter the 30 drugs again. The only way around that is if they set up, or you set up for them, if your organization has approved a way for you to do that, an account in mymedicare.gov, which requires a login and password. And then if they log in using that login and password, then it will show you what plan they're in. It will save their drugs from each time, save their pharmacies, saves a lot, show if they have full or partial extra help or not. So it's a huge time saver. But now that it's required, each organization has to think about, like, ethically, do they want their staff creating a login for a client into their Medicare account? Because now it's not just the Plan Finder account, it is their Medicare account with all their Medicare billing information. So different organizations are making different decisions on that. So that's something you have to think about. We at NILAD can share what between PBU and EFLRP, we've worked out different ideas, and we can just share that offline because there's people not on NILAD on this webinar. If you have Epic, it will not show on Plan Finder. So you have to take that into account in figuring out what the cost will be. You have to sort of guesstimate, well, this plan might be worth doing even though it's very expensive because the cost will be this much cheaper with Epic. I did find this is private site. It's a commercial site, qimedicare.com, but it's pretty good because it really compares a lot of the cost sharing, like just makes it more visible. It's a site you might want to look at because it just shows it's still being uploaded with 2021 costs, but I got a lot of information on the plans from that site. So they've made some changes, as I understand it. I haven't actually, I don't know, I haven't actually tried it yet for 2021 except for just looking at the plans. But if the default sort is better from lowest out-of-pocket cost and premium, I understand it's easier to designate which pharmacies you want. It's added in the drug list, you can designate that something you're only filling once or twice a year as opposed to only monthly. Apparently there are more footnotes, including like which frequency is not covered. Let's see, we haven't looked at this yet, but there is this new benefit you may have heard about in the news that Trump announced with great fanfare, that Medicare, both Part D and Medicare Advantage plans, some will now offer insulin at a max of $35. And this will come up on Plan Finder. And there's also in our Excel sheet, I've added a column that shows if the plan is one that is offering this $35 capped insulin. It's called Senior Savings Model Insulin Cap. So, and the same thing on the Medicare Advantage chart, which is also there on our website that you can download. There are, I guess, opioid treatment benefit options. It allows you to filter if you want only HMOs or PPOs for Medicare Advantage. And there is a new renal dialysis benefit that you can search for. And I want to just talk about some of these changes. On Medicare, when you look on Plan Finder for Medicare Advantage plans, it tells you estimated annual costs, but it's absolutely not reliable because it's just guessing at what cost you're going to use during the year. Doesn't know whether, just like you don't know whether you're going to need some of those expensive Part B administered drugs. You don't know whether you're going to go to rehab. So instead of looking at those costs, I recommend that you look on the plan's website or in this QI site for some of the most expensive drugs. I mean, not just drugs, services, to make sure your client knows that what the co-payments will be for these Medicare Advantage charge. What's the hospital deductible? What do they charge 20% for? Because this won't be in Plan Finder. It's only going to be on the plan's website. So that's some of these things that are ambulance charges. I mean, those are expensive. And if you have Medigap, you don't have to think about it. But if you're a Medicare Advantage, you do have to think about it. They're not cheap. You have to worry about which providers are in network. And there are these new services that are covered by Medicare Advantage, which I'm still going to go over. Dialysis, acupuncture. All of these are great that they're offering them, but you might have to change your provider of these services if you join that plan. So for anyone thinking about Medicare Advantage, I have to really think about all these different factors and think about, are they eligible for Quimby, which might make it cheaper because, as someone pointed out before, either Medicaid or Quimby could cover a lot of the Part A and Part B costs. But if they're not, they're looking at being responsible for those costs. Some reasons why there are such a new crop of Medicare Advantage plans is that this change in federal guidelines that is no longer required that a company offer plans that have a meaningful difference between their coverage. They can offer 20 plans that sound alike, look alike, and might have just the slightest difference. So for example, here are 7 Medicare Advantage plans. I just picked one borough, just as a sample, in the Bronx, by WellCare. 7 MAPDs. And they have names like WellCare Absolute, WellCare Summit, WellCare Today's Options Advantage Plus 550B. All of these names. 3 are HMOs, 3 PPOs. How does somebody weed through which is better? So, when someone tells you which plan you have, WellCare, you can see it doesn't matter. That name doesn't matter. You have to drill down. Which plan are they in? It's become more and more difficult to compare between Medicare Advantage plans. Now, these dual SNPs, the plans that cater to Medicaid beneficiaries. In fact, you have to have Medicaid to enroll in these plans. But be aware that these are not Medicaid plans. They are Medicare plans. So unless they are linked to a Medicaid plan and they are becoming a hybrid plan, they are just a Medicare plan that may coordinate with Medicaid and market to Medicaid, but they're not Medicaid. So, but boy, do they market. Like, I am going to be newly eligible for Medicare in a few months. And I have received so many mailers from plans saying, do you have Medicaid? Do you have Medicare? Join our plan. Now, why would they think I have Medicaid? but they are marketing like crazy. And anyone with Medicaid is going to think, oh, this is for me. This is the plan I need to join. Now, they could be of benefit to Medicaid recipients because all their network providers are required to accept Medicaid. So for that 20% coinsurance problem, as someone very wisely raised in a question before, if you're in a Medicare Advantage plan and you have a high 20% Part B coinsurance, if you're on Medicaid, doesn't Medicaid have to pay that? Well, yes, in one of these plans, because the providers must accept Medicaid. But in a regular Medicare Advantage plan, not all the providers accept Medicaid. So, in fact, many of them probably don't. So they could still bill a Medicaid recipient for the 20% or whatever the Medicare Advantage copay is, even though they're on Medicaid, all right? Because they're not Medicaid providers. In these dual SNPs, though, the provider has to take Medicaid to wrap around the Medicare. So, that could give a lot of peace of mind to a Medicaid beneficiary. It's supposed to do some coordination. But, the downside is still there's a network. They're not PPOs. They're always HMOs. And someone who has very specialized needs, they have cancer, they have MS, they have, other diseases, they have their network of physicians that they've been relying on, they might not be in one of these plans. And if they want to continue treatment with with those providers, it might be more important for them to find a plan that's not a dual SNP and figure out how they're going to afford that. All of these plans are now marketing a lot of extras, and it's our job to really look under the hood of those to see if they are really meaningful or if they're just cosmetic and look better than they are. So, and there's a lot more dual SNPs that have launched this year compared to previous years, or they've expanded to new counties. I really went through these lists. There's all of these plans have been expanding to new counties, or they're adding new dual SNPs. And why are they doing that this year? Because CMS in New York have worked out an agreement that they're going to start default enrollment, which will mean the mainstream managed care member becomes enrolled in Medicare. They are going to be default enrolled into a dual SNP with the right to opt out. Now, this is not approved yet. It's not starting yet, but it can start. And they will also default stay in their managed care plan so that the two plans together, the dual SNP and the mainstream plan together, will be one mega plan called Medicaid Advantage. That will be like a Medicaid HMO combining Medicaid and Medicare. So the well duals without home care will be in those plans. Duals who had home care through their mainstream plan will be default enrolled into a Medicaid Advantage Plus plan. So that plan includes basically MLTC along with all Medicaid and Medicare services. So this is coming in 2021, and this explains a lot of growth in dual SNPs around the state, not only in New York City. Some other changes. All right, you're going to see plans advertising that they cover dialysis now. Now, until now, if you're on dialysis, you were excluded from Medicare Advantage. You just simply could not enroll in a Medicare Advantage plan. This wasn't about being Medicaid or Medicaid, just you were excluded, and that you got your dialysis through Original Medicare, and you got everything through Original Medicare. The only exception to that was if you were already in a Medicare Advantage plan and you developed advanced kidney disease and you went on dialysis, then you could stay in your Medicare Advantage plan and be on dialysis. But I think then the dialysis was administered outside of the plan, like fee-for-service. So starting in 2021, people with end-stage renal disease on dialysis may enroll in a Medicare Advantage plan. Now, so that means that all the considerations we always think about for Medicare Advantage will have to be thought through for these people. Is the dialysis center in the plan's network? Is the client's nephrologist, their kidney specialist, in the plan's network? If they're waiting for a transplant, is the facility and the surgeon where they plan to have the transplant in network? Now, what I learned researching this was that the plan will not be responsible for the actual cost of acquiring the kidney. I guess that will still be through original Medicare, but the surgery and all the pre and the post, all the, it's complicated doing a transplant. So all of that care will still be by the plan. That all has to be a network. So definitely this will take, it's a factor for counseling. There, just very briefly, we're running out of time. All the plans are offering these supplemental benefits. Some of them are more health related, like home care, adult daycare. There's this acronym SSBCI, Special Supplemental Benefits, just starting really this year. Fourfold increase in plans offering these since last year. Last year was really the first year offering them. So these will be things like Meals on Wheels, non-medical transportation, wheelchair ramps, air conditioners, air filters, and home care, respite care, reduced cost sharing or deductibles for different conditions. So this is really new. I mean, they can say you have diabetes, we'll give you reduced cost sharing for certain diabetic services. Like, it used to be that they couldn't target any particular medical condition. That used to be considered discriminatory. And now they can market to people with that condition. But again, all of these things, you have to look under the hood and see really what the benefit is. Because when they're offering this home care, look, most states don't have Medicaid home care like New York State, where you could get 168 hours a week. Most states have very little home care, so this could really be a draw. In New York, 10 hours a month of home care is not going to be considered that much of a draw, unless someone's, wealthy and not planning on going on Medicaid, then that might be a nice draw. But I don't think that these are going to be that generous in terms of what they cover. Also, adult daycare could be covered. But this is not all plans. Do not assume that a plan's covering this. And if they are, we have to check really what is the benefit. Acupuncture and opioid treatment are both, acupuncture is brand new this year in both original Medicare and Medicare Advantage, but it's very limited. It's only can only be covered for one reason, for lower back pain, nothing else. So lots of other reasons people use acupuncture, but Medicare will only cover it for lower back pain, and it has to meet these criteria. The pain has lasted more than 12 weeks, have no known cause like surgery or disease. So it's and there's a maximum 12 sessions within 90 days, and then you could get more if you show improvement. So Medicare Advantage plans might be hawking this, right? We give it acupuncture. Well, again, that people have to know it's these limits. And then if they have a favorite acupuncturist, that person's got to be in network or it's not going to be covered. there's a new demonstration program covering hospice. Now, what's new about this within Medicare Advantage is that up till now and normally, the hospice benefit itself is covered by Medicare, but it was carved out of the plan. So if you were in a Medicare Advantage plan and you enrolled in hospice, you'd stay in your Medicare Advantage plan, but the actual hospice benefit would be given fee for service, billed for outside of the plan. And in that way, the member would have the choice of picking which hospice they wanted and not be limited to network. So only one plan in New York State is participating in this demonstration, and it's VNS Choice Total, only in New York City, Long Island, and Westchester. But just be aware that you might see this marketing, and that's the only plan that is offering it. Now, other plans, I understand, can start offering some palliative care to enrollees. I'm not clear on exact, it's not hospice care. You wouldn't be enrolled in hospice, but some palliative care. But since a person is not in hospice, they're also still getting other medical care. But be on the lookout for other palliative care. All right, so very quickly, if you get Medicaid, if you are not in a Part D plan, when Medicaid is approved, Medicaid assigns you to a Part D plan, as we mentioned before. And in the meantime, you use something called LINET for your coverage. And that is a national plan that the federal government has contracted with that covers all Medicare beneficiaries who have extra help but are not yet in a plan. So it's important to know because they get the full extra help subsidy even though they're not in a plan yet, because that takes about 2 months to get into a plan if you weren't already in one. So there's more information there. The LINET can be retroactive, so you can request reimbursement if they've paid money and they need reimbursement. So there's some information about that. Now, what if they were already in a Part D plan once they get Medicaid? So again, it can take, there's a lag until CMS tells the plan this person has extra help. So in the meantime, you can just show the pharmacist your Medicaid approval notice or proof that you receive SSI or a screenshot that shows you have active Medicaid as best available evidence that you have extra help. I know we are now out of coverage. So I'm glad to stay on for 10 minutes. We're just about done. CLE people, even if you sign off now, you'll still get your credit. But I can stay on for, I'm just gonna run through these last slides because we really are almost done. And then we could take a few questions. So the person can also, they've paid the plan at the full Part D rates, but they're on extra help. So they can get reimbursement from the plan. So that's, in that case, that's where they get reimbursement. In the other case, if they weren't in a plan yet, they get reimbursement from through LINET. All right, but all the links are in here. I don't know why. Hello. Well, that's nice. My screen froze. Okay, Epic. We talked briefly about Epic, but I just wanted to talk about what a great subsidy it is. So it subsidizes a premium up to $42.27, and that might sound familiar to you because I said before with extra help you get a subsidy of up to $42.27. If you have both, you can get a subsidy of double $42.27 times 2. So you could pick a fancy plan if you want. If you have a deductible, you don't get that subsidy. You get a credit against the deductible, but it's worth over $500 to you. Now here's how Epic wraps around the copays. So if the Part D copay is over $55, so let's say it's a high tier 6 drug, the copay is $300 a month, which is not unusual, okay, for really expensive drugs. Maybe that's 38% of the cost of the drug, or maybe it's a tier drug. Epic will pay most of that. You only pay $20. So Epic's paying $280, and so on if the Part D costs are below. So you can see the Epic member pays at most $20. So that's a fantastic subsidy. When you do the Part D plan finder, it will really help you to try to figure out, is the person going to be eligible for extra help? Because then you can, sort of calculate it, not extra help, but Epic, that none of the copays would be more than $20 for fill. It will even wrap around extra help. So right now, the maximum extra help is going to be $920, the copay, but Epic will pay a good chunk of that, and the Epic member would pay only $3. So that's a great subsidy. The cost paid by Epic help count toward that TROOP, the true out-of-pocket costs, and that's also true for ADAP. So what Epic pays helps you moves you through in that to catastrophic coverage. So an example on the previous slide, the 300 is counted toward TROOP and it's also counted toward the spend down, can qualify you for Medicaid and extra help. And that's more on enrollment periods, which I'm not going to do. So I could take a few more questions if there are any. You guys are troopers for hanging in.
Okay, it doesn't look like we have any questions yet, but I'll see if anyone.
Okay, well, anyone can unmute themselves too, I think. I'm sure you're tired.
It looks like we have a couple hand raises, actually. So,
can they just unmute themselves?
I don't know if they can or we have to do it.
Okay, click to mute yourself. Oh, how do we? Oh, there's got to be a way to unmute.
Well, I think we can unmute them.
Okay, can you figure out how to do that?
Yeah, so I'll start with Elena Gellerman has her hand raised.
Okay.
Okay, so you're unmuted. Let's see if it works.
She might have to unmute herself too.
Yeah.
Elena, you might have to unmute yourself too.
Oh, it popped up as green. That's a good sign. Looks like Rebecca also has her hand raised, so I'll try and unmute Rebecca.
I mean, you could unmute everyone at this point.
Oh, okay.
How do you do it? Is everybody trying to unmute themselves? Oh, so frustrating.
Okay, I put unmute all. So it looks like everyone's self-muted now.
Everybody's unmuted?
On our end, yeah.
All right, well, I'm hearing sounds. If you have a question, go ahead and ask.
Okay, Elena said she had a problem unmuting herself, but her question is, what if a client has an SNT and applies for MSP? Will the client have extra help for the year?
You want to answer that, Sarah?
Yes. I mean, it depends on when they got MSP, but yeah, if you use an SNT to qualify for MSP, then MSP provides, you get the same benefits that you would get from MSP if you qualified, you know, if your income was just under the limits otherwise. So if it's if you qualify in the first half of the year, then you get MSP for the calendar year. And if it's in the second half of the year, then you get, or extra help rather, you get extra help through the end of that calendar year and the next calendar year. So yes. And how about Epic? Well, Epic, you can't use an SNT to qualify for Epic, I don't believe. And people with full Medicaid cannot use Epic. So if someone's using an SNT for full Medicaid, they likely would not need Epic.
Right, unless they're using it just to qualify for MSP, and maybe they can. All right, any other questions? Sorry, this part, I don't know why
Okay, another one, does Epic still give you one SEP automatically? And the answer, I believe, is yes. Okay.
Yes, that is another. I think that one is on. In the next set of slides, there's a bunch of SEPs that I didn't get to cover. But there's just a million of them. But yes, with Epic, you have a one-time SEP once a year. Right, it's on. Sorry, the slide numbers didn't make it on. But it's close to the end. The SPAP Epic SEP. It's on the screen now. And there are a few others. Move. If you lose Part B. There's so many of them. That would be a whole other hour training. All right, well, if there's no others, I'll send out a correction on that one and see if we can answer any of the other questions that were posted in chat. If you have other questions, feel free to email eflrp, eflrp@nilag.org, or you can email me. And thanks for participating, everyone. We're going to close the webinar. Thank you.
Thank you. Thanks so much.
Thank you.
Thank you. Have a great evening.
You too.
Thanks.